Good afternoon, everyone. Happy Friday. Thank you so much for joining the Ohio AAP for this training. We want to thank the Ohio Department of Health for their support with the Lead-Free Ohio program with Ohio AAP. We are excited to share this information with you today. My name is Alex Miller. I'm the program manager for this program. Our speakers today are Dr. Newman and Dr. Tien, and I will allow them to introduce themselves now, as well as our medical director, Dr. Thakur.
Hello, good afternoon, everybody. Thanks for letting me speak briefly with you today. My name is Dr. Nick Newman. I contribute to the Ohio Lead-Free program as a environmental health consultant, and I'm a assistant professor of pediatrics and environmental health at the University of Cincinnati, and I run the environmental health and lead clinic at Cincinnati Children's Hospital.
Hi, I'm Matt Tien. I'm a general pediatrician at Metro Health System in Cleveland, Ohio. And yeah, I appreciate the opportunity to be here during your lunchtime. Thanks a lot.
Hello, everyone. My name is Rupa Thakur. I'm a primary care pediatrician at the Cleveland Clinic, and I'm the medical director for the Ohio AAP's Lead-Free Ohio program.
Great, and none of these speakers have any disclosures. There will be one CME credit available, and I will send the CME survey out on Monday. And you can ask any questions that you have in the chat box throughout the training, and we will answer those. Just a few housekeeping items. We do have our Lead-Free Ohio website, our toolkit, as well as resources in English and Spanish to be used with families, and you can access those on our website. Now I will pass it over to Dr. Newman to kick us off.
Hello. The main topic of today is going to be screening or testing for lead, and basically how to get that done. But I just wanted to highlight a little bit, like, why do we test kids for lead? I mean, other than it being like the state law, right? So, I mean, the main reason is we put into effect a whole bunch of different things to prevent kids from getting exposed to lead, because we know it's bad for neurodevelopment and also other organs. And basically what we're trying to do by testing is to figure out where the primary prevention system has failed. So, like, has there been a problem in a home? Is someone bringing something into the home that could be causing this problem? And, you know, so once we identify a case, then we need to deal with that child medically, but then we also have to deal with the source, and that might require some environmental intervention. And most of those interventions are public health interventions. And so there's a back and forth between public health and clinical medicine here that's, I think, very important. And the goal, you know, our first goal was to keep all the kids from getting exposed to lead, but like our secondary goal then is to try to reduce the lead level as quickly as possible, because the research would suggest that it's not just how high your lead level is, but how long it stays high. So like the idea of kind of the area under the curve, not just like a single point on the line, if that makes sense. Next slide, Alex, please. So who should have their blood tested for lead? So according to state law, there's children live in high-risk zip codes should have their lead tested, and children insured by Medicaid at 1 and 2 years of age. So the zip code basically applies to children of, regardless of what their insurance or no insurance, they need to be tested, and the testing is done at 1 and 2 years of age typically. Additionally, further testing, let's say between ages 3 and 6, may be in kids who continue to be in a high-risk environment, or as the law says, for children who weren't tested previously. So there's kind of a line between who must be tested and who's recommended to be tested. And then, of course, like things that put them at risk are children who live in pre-1950s housing or 1978 housing with a recent renovation, or if there's some clinical suspicion of lead exposure. And I just bring that up because the way the law is written, it actually states that if the clinician feels that there's some other reason that's presented as to why the child needs lead testing, it can be done. Next slide, please. So if you look at children in Ohio, and I think if you click once, this is a little animation. So 80% of kids in Ohio are exposed to lead-based paint, dust, or chips. And I would say, I would emphasize the dust, because the dust is the most common source of exposure. The children sitting there chewing on the paint chips falling off the house, that still happens, but that's not the main scenario. Mostly it's dust from deteriorated paint that's finding its way onto the floor, other horizontal surfaces that the children are interacting with. The next things would be occupational take-home exposure. Water is also a source, and it's somewhat complicated because in general, the levels in the water are fairly low, but the amount of water that we drink is what kind of amplifies that. And then of course there is lead in the soil. If you've been following the news, there's been a bunch of stories about heavy metals in food, baby foods, spices, etc. And then toys, mostly those painted with a lead-based paint. But none of these things are supposed to have lead in them. Like toys are not supposed to have lead in them. Herbs are not supposed to have lead in them. Neither are cosmetics. But often some cosmetics that are more culturally based, maybe from brought from outside the United States, lead may be one of the main ingredients in addition to some of the ceremonial powders and traditional medicines. Next slide, please. So the other way that lead can be brought into the house is by a caregiver or an adult who has a high-risk occupation. So like construction is, when I was a fellow, I worked at one of the federal agencies, and we were looking at sources of lead in adults. And construction was by far the biggest growth area. And so a lot of parents are working in construction and they're bringing this stuff home. And then, obviously people who are working with lead, metal directly, batteries or recycling, welders, sometimes police or military personnel, as they have to certify at least once a year with their firearms, will sometimes bring lead home. And then things that are less common, although do come up, people who are working with glass, or artists, depending on what media that they're using. Pottery sometimes can contain lead, mostly decorative items, right? And then auto repair, simply because leaded gasoline was used for so long, it contaminates the roadways. Next slide, please. And so I just want to reiterate the Medicaid testing requirements. So that applies to 12 and 24-month-old children, and that's mandatory for Medicaid that they be tested. And then children who are older, up to 72 months of age, must have a lead test unless they've been previously tested. So that's the absolute requirements. Now, there may be other situations where you as a clinician are just like, yeah, I think we ought to test this, or there's some other thing going on, or you have a question of whether they need to be tested. And that's what part of our role here is, to also help to answer some of those questions too. Next slide. And I think that's the last for me. Yes. So I'm going to mute myself, and we'll see you later. Thank you.
Hi, thanks, Dr. Newman, for the great introduction, and also for the opportunity to present. Thanks to the Ohio AAP for inviting us to talk a little bit of some of our work that we've done here at the Metro Health System in Cleveland. Before I dive into this little cartoon that I drew, I just wanted to say that it's fun to be back with the Ohio AAP, because that is really how our how my official involvement in lead prevention work for our health system started is with an Ohio AAP QI project in 2020. Before that, I was a pediatrician. I've worked as an outpatient pediatrician for many years, and knew about some of the lead testing requirements that Dr. Newman mentioned. But to really get into the work was I got involved too in Ohio AAP lead QI project, and I was telling these guys beforehand, I really think it was one of these home run type of QI projects that the Ohio AAP sets up. Not only did I, get able to check off my MOC credit, but it really led us to sustained changes that we've made across our health system, and that we're trying to help spread throughout our region by collaborating with other health systems. So this little cartoon I drew just shows that me in 2020, lockdown in the pandemic, sort of getting some Zoom meetings in for this lead QI project. I thought it was going to be like any other QI project there in the second panel, where I turn in my data collection sheets, and then I get that I get my MOC credit in the end, and then I'm done, and I don't have to worry about MOC Part 4 for a little while. But what happened in the third panel was that our health system decided lead screening is going to be a system quality goal. And they said, "Hey, Matt, you're doing some lead work too. We're gonna help put you sort of at the helm of some lead prevention work. We'll give you some team support to do that." And I said, "Well, we better get back to work. I'm not done with this stuff." And so the next upcoming presentation is really going to talk about how we went from just being a QI project to really setting up some meaningful changes at our health system on both how to improve our lead testing rates, but also, as Dr. Newman was alluding to some of the care management that happens after you find patients with elevated lead. So yeah, that'll be it. That's the setup. We'll go to the next slide. So as I mentioned, our health system said we're going to do a system quality goal. And I guess what I hope that some of the folks listening to this presentation get is little bits and pieces that you might be able to take and apply to your own situations. Having a system quality goal was really helpful because that means the folks up in the C-suite were buying in. They said, we want to emphasize lead testing. That meant from the top down, people were going to fall in line. That means we had resources in terms of personnel to put on this project. And so I think if you can advocate for that, this is something that's an achievable quality goal, is improving lead screening. And as you can see from the graphic, we used a metric for our system quality goal of the percentage of patients with a lead test by their second birthday. These are our Medicaid patients who are required by law to have a lead test at 1 and 2 years of age. So it's maybe not it's kind of a crude metric, like you're supposed to be doing it at 1 year old and 2 years old. This didn't include high risk zip codes, but it was good enough. And I think that's maybe a lesson learned too. If you have a measuring stick, it might not be the best measuring stick, but it was enough to start our work. And we could see that as we were really getting started with putting our team together in May 2021, we were at 56%. So we had plenty of room for improvement. Only 56% of our patients that had turned 2 years old in the prior year had gotten their lead test by that second birthday. So what did we do? We really tried to put together our whole health system. We tried to organize a lead coalition, I guess is what we put down, is how we labeled it. But it really meant that all the little different departments and different teams that had been working on lead throughout the years in their own little corners, their own little silos, were able to sort of funnel together into our lead coalition. We put together monthly meetings of different subcommittees that were focused on different areas of lead prevention. And so that gave us a cohesive approach to lead for our system. And again, having a system quality goal allowed us to sort of organize in that manner. And not only were we able to put together a lead coalition that was co-chaired by myself and an awesome nurse process specialist, Jen Conti, who I think is on the call and is helped leading these efforts with me. it made me and Jen sort of the point people for the people internally to come to talk about lead, but it also gave us, I think, the authority to sort of talk to some of these external bodies. There's a lot of energy and movement around lead right now from the Lead Safe Cleveland Coalition that we have in our area, the county and Cleveland Boards of Health, WIC, the State Department of Health, the insurance, Medicaid, managed care organizations. So that I think was also helpful. So another tidbit that I would pass along is like trying not to just work in your little corner, but trying to get some system buy-in and system organization is helpful on moving forward. Next slide. So what did we do? Some of it was really basic stuff that we learned in my Ohio AAP led Q-High project, which was that drawing the blood test in the clinic is the way to go. I would say that I think we sort of knew that, but we weren't really sure we had the wherewithal to pull it off, and making it a system quality goal that our system was dedicated towards really helped. So our nurses in the main campus pediatric clinic decided we're just going to start drawing leads in the clinic. And these were venous lead draws that they were doing. As you can see, prior to the project starting in the fall of 2020, we were less than half the time patients were showing up for their visits. Only 48%, 39% were getting their leads drawn that day. They were almost always being ordered. You can see the red line hugging the blue line, but that orange line of how many percent were actually getting performed that day was way low. Like basically patients didn't want to walk upstairs to go to the lab to wait. It's in our same building, but they still didn't want to, bundle their kids up, take another place, wait in another waiting room. So this is really, I think, a best practice that we were trying to implement was like draw the lead in the clinic when they're a captive audience. And did it work? It worked. You can see the subsequent months, we were getting 80, 90% of the time, the patient was getting that lead drawn that same day. Sometimes there was a failed venipuncture. Sometimes the parent really said, I really have to go pick up, the sibling, but, much, much improvement. And so next slide. We had to try to convince our other sites all across our satellite network. How can we do the same thing? And I'll highlight a few things. We assembled, having a good report was very key to that. And so we could show different sites in real time, like, how are you doing at this? What we did was we could see for all the visits to a particular site, we could audit the patient's health maintenance status at the time of their visit. Were they due for lead at that time? The other hat that I wear for our health system is in informatics. So I realized looking at our electronic health record that it did keep track of what was the patient due for lead at the time of the visit. And I could look backwards in time to see for each particular visit, was the patient due for lead? So, okay, the patient's due for lead. Now we can look and see, was the lead ordered at the visit? And then we could see, was it drawn that same day? And then we could add some filters, including the different departments across the health system, the age of the patient, whether it was a well visit or a sick visit, and who was the clinician who saw. So that way we could see if a particular site was not doing well, we could see, oh, is it just this one department in the site that's having trouble? Is it because you're different age, you're doing it a great job at 12 months, you're doing a bad job at 2 years? Is it because you always remember to do it at a well visit, but you always forget to do it at a sick visit? Is one clinician in particular not really good at ordering not good at remembering to order the test? So we could sort of use those filters to sort of drill down and figure out what was going on. We put together a clinical workflow committee, and this is a group that met monthly so that we could try to problem solve what was going on. So we could try to figure out which sites were sites that we needed to connect with. And we actually went out to visit some of these sites. This was really still ongoing during the pandemic. So most of these were sort of virtual meetings, dropping in Clinic A's monthly provider meeting and say like, hey, we'd like to talk to you guys about lead testing and the importance of this. This is a really big issue here in Northeast Ohio. And so we met with nurse managers. And so we really tried to sort of share this data with the people who are on the front lines. And another way we shared the data was by starting a a lead quality newsletter. So we would send out, we've been sending out once a month a little report on how different sites are doing at ordering and drawing the lead. It's one of those things where I think you can't get better at something until you measure it. And so really measuring it and then showing to the folks is half the battle. I'll go to the next slide and show you an example. So as we're trying to move this effort system-wide and saying like, hey, we're not sending kids to the lab anymore for lead, we're drawing it in the clinic. This is how you're doing. And site A, you had 22 visits in the month of June. It was ordered, the lead was ordered 17 of those visits. It was drawn 15 times of those visits. So maybe we could shore up our ordering a little bit. And then you can see in July that 7 out of 7 times it was ordered, 6 out of 7 times it was drawn. In August, 11 out of 11 times it was ordered, and 11 out of 11 times it was drawn. We're still working on buy-in on some of our sites here, but we really have gotten quite a few of our, I would say the majority of our sites are now drawing the great majority of our sites are drawing the leads in the clinic. We still are trying to work on some sites, but having this data, having this report to show folks, it's been really helpful. At the bottom, I have 2 little bubbles there. So the first one that says lead drawn on the same day of the visit. Overall for our system at the time that I prepared this visit, we had gone from pre-project where only 49% of the time would a lead get drawn on the day of the visit when the patient was due to now 72% of the time. So we still have some room for improvement. We'd like to maybe be above, we set a goal for ourselves to get to 80%. We're kind of struggling to try to make it there, but we've shown some great improvement. So your odds of getting your lead test done when you show up and you're due is much better. And that system quality goal that I talked about in the second bubble, what percentage of our Medicaid kids had a lead test by their 2nd birthday, we were able to rescue that from 56% in May to the end of the year. When I prepared this slide, we were projecting to be at 65%. And I'm happy to say that when I looked at our numbers today for our health system in January, we're at 66%. So we've really moved the needle. And I say that just to say that if you were to engage in this with your health system or your practice, it's something that you can really show some wins in a short time, because it's not like some other quality metrics like the immunization metric where it's going to take you a couple of years to really show improvement on all the different, because the series takes so long. Getting a lead test done, you can really show some good improvement by changing your workflows. Next slide. Okay, so we have improved our ability at our health system to get the lead test done when a patient shows up. That's helping us comply with Ohio law and of course, good medical practice. But the next things are, I think Dr. Newman was sort of alluding to, what can we do to manage those patients or help provide resources for those patients when they have elevated lead levels? And then it's all well and good that we're doing some better testing for patients when they show up. But we notice that we're a safety net hospital. Many of our patients don't show up in a timely fashion. And how do we track down those patients who are missing their lead test? Those are still 2 topics that I just want to talk a little bit about how we tackled those here at Metro Health. So next slide. How are we managing our patients with elevated lead levels? I'll talk about that first. Just for scale, I wanted to show you how many patients are we testing and how many patients are having elevated lead levels for our health system. This is looking at a week by week in the months of August and early September. You probably have seen that trend that in the warmer months, we have more elevated lead levels as the kids are more outside and windows are more open. So we test on the order of about 100 to 150 lead tests per week. And we are getting about 10 to 20 elevated lead tests per week. So that just gives you an idea of what the scale of the problem that we're trying to deal with. Next slide. That's across our whole health system. Next slide. So what do we set up for our management and care coordination? Well, we set up all our elevated lead levels to go to a central in basket. We felt that was helpful because not all providers would necessarily pay as close attention to the elevated lead levels or they're just understandably so busy with other stuff that managing and tracking down a patient with elevated lead and giving them education over the phone was, I think, a tall ask. So at this point, we've actually changed it so all our elevated lead levels go to a central in-basket monitored by our awesome pediatric lead nurse. I'll talk more about the composition of our team, but we have a full-time lead nurse here at Metro Health now. She provides a phone call to the parent and guardian, parent or guardian. Sometimes the parent and guardian is hard to reach. They usually try several times. They'll use text messaging. They'll use the patient portal to message if they're having trouble. They'll send out a letter as a last ditch effort if they can't reach them. They'll loop in the PCP, so the PCP is kept up to date about the elevated lead level and whether the parent was able to be reached and given education. For the patients with a lead level of 5 to 9, and I think maybe Dr. Newman can address this later about the recent CDC lowering the reference level for lead down to 3.5. But currently what we're doing is for 5 to 9 at lead level, we'll provide that education on lead from the phone, from the pediatric lead nurse by phone, and we'll also send out a written letter about the usual preventive measures to take at home that you also know how to do, telling patients to wash their hands, keep their shoes at the door, try to block off areas that might have peeling, chipping paint here. So run the water, wipe things down on a regular basis, et cetera, et cetera. And we will arrange for a follow-up lead test to be scheduled in 3 months. The lead nurse will schedule that. That can often just be a lab visit or a nurse visit. She'll add elevated lead level to the problem list to make that more prominent on the patient's chart. And we have a health maintenance modifier that we add so that also makes it more prominent to the provider that might see them next, and in the patient's own patient portal that there's a every 3-month lead level that should be checked. We'll make that referral to Help Me Grow for the kids who are less than 3 years old. She'll add them to a patient roster in the electronic health record for tracking. And if that follow-up lead level in 3 months is not decreasing, we usually try to make an appointment with the PCP at that point to sort of delve more into things and figure out what's going on in more in depth. For the patients who have a lead level of 10 or higher, our current workflow is to schedule all those patients in our pediatric lead clinic, which we hold 1 session per week at our main campus. There's a nurse practitioner that mans that and also is assisted by our pediatric lead nurse and our community health worker for lead. And so the main thing that happens there is just a higher level of care coordination. As Dr. Newman mentioned, there's not tons of medical intervention that usually happens, but trying to get the public health interventions into place and the resources into place so that that lead level can be reduced as quickly as possible is the goal of our higher level of care coordination in the lead clinic. Next slide. Just talking about what that higher level looks like for those patients that go to our lead clinic. That involves more communication with the health departments. So we have, I think, an area for potential improvement that I think that might be a springboard for another discussion with maybe the next Ohio AAP training or something like that, but how to work best with your health department. We currently just sort of have them on speed dial. We have them on email. We sort of know who we're talking to. We can get information quickly on where the process is for patients. Our county health department is better at sending us the lead investigation report than I think our city health department has been sort of reluctant to sort of openly share those reports with us. But we do try to strive for some open communication so we can figure out where the roadblocks are for patients who seem like they're stuck. You haven't gotten your investigation yet, or you have had the investigation yet, but you're waiting to get some paperwork done, to apply for a grant, et cetera, et cetera. We work with our legal aid society folks. So we have this medical legal partnership so that they can take referrals from us for patients who might be stuck with a landlord who isn't doing what they're supposed to be doing, so that they can know their rights on how to get out of that situation and how to address those situations. We have teamed up with our pediatric neuropsychologists, so they actually have blocked off time on Friday afternoons during our lead clinic so that they can evaluate patients who have had elevated lead levels. They have a list of criteria of which of our patients they would like to see, and provide an in-depth neuropsychology evaluation so that we can best advocate for their educational interventions down the road. We've done some home visits for patients who really have trouble getting in for lead clinic. And we try to do some case reviews as a team monthly, where we really talk about some of those most challenging patients that we're really having trouble getting going in the right direction. We also, I'm going to put my plug in for Dr. Newman as an expert consultation for phoning a friend with in his official role with the PACU. Let's see if I can get the initials right. Pediatric Environmental Health Specialty Unit. When we've had some cases that we really didn't know what to do with, we needed some expert guidance. Dr. Newman's an awesome resource to be able to call, and I'm sure he can put the chat in the chat how to reach him. So he serves our region as a great lead expert. So if you have cases where, like we had a case where we weren't sure, like, do I keep this kid in the home or not? Or it seems like the home is safe, but the lead keeps on bouncing back up. Can we maybe do outpatient chelation this time instead of inpatient chelation? Great resource for questions like that. Next slide. We've done some closer monitoring of how we're following up with our elevated lead levels. So we know that we're supposed to follow these patients on a regular basis, but are we really doing what we're supposed to? So we know we have this roster in our EHR for patients with elevated lead that our pediatric lead nurse manages. She tracks when they're supposed to get their next scheduled blood draw or when they're supposed to get their next lead clinic follow-up appointment. The roster sends her a tickler if a patient has not followed up as they should, so that we can try to stay on top of our patients that way. We also set up a monthly report so that patients who seem like they are way overdue for a repeat lead, if someone has fallen through the cracks of that sort of workflow in the top box, if it's been more than 4 months since that last elevated lead was checked, then we get a report each month. Our community health worker monitors that report and tries to sort of schedule those kids in, like, hey, it's been 6 months since we've seen you, what's going on? And so on the bottom graph there, we have a metric that we're tracking, how many patients of ours who had an elevated lead test, within 6 months that elevated lead test was followed up with another lead test. And so you can see we're bouncing around 50 to 60% last year. And now the last few numbers, some of them have been 75%. So we feel like getting these reports is helpful and help in kids not falling through the cracks. And it's a way to sort of show, are we providing timely follow-up for these patients, at least monitoring their lead levels. Next slide. Okay, so that was a little overview of our care management and care management of patients who had elevated lead levels. I said that we also would maybe have a little bit of a discussion about how do you track down those kids who are missing their lead tests. So I think if you set up a system quality goal to what percentage of your kids are getting their lead tests done, one bucket of kids is who are missing their tests. They came for a visit and you didn't get it done when you had a chance. So that's one bucket, and that can be addressed by those best practice workflows we talked about earlier on. The second bucket is those patients who just haven't come in at all. Many of us work with these sort of more at-risk populations of patients that don't have super regular well-child follow-up. It's still the COVID pandemic. And then there are some patients who just don't come to see us anymore. They've found another provider, maybe they've moved. So there are some patients who maybe they're really not our responsibility anymore. How do you figure that out? So we'll talk a little bit about that. Next slide. We do some outreach. So one way to reach those patients is we set up a automated text message. So we write a report. This report looks for our Medicaid patients every month, as if they've turned 16 months, every week. It goes out once a week. So every week it looks to the patients who turned 16 months old, 19 months old, and 22 months old. And you can argue with what the ages really should be, but we feel like those are ages like they're really pretty overdue. So we send out a text message to those patients to say, hey, we noticed that you're overdue for an important test. Please text us back. And the number that we ask them to text back to is our pediatric lead nurse. That takes a lot of work out of the system of calling patients with wrong numbers, trying to call people who won't pick up the phone. So the text messages has been a handy, low effort, low yield. We don't get that many messages back each week, a handful of messages back each week, but it takes us no effort to do it. And we get a handful of patients in each week who respond to the text message and say, oh, I didn't realize I was due for a lead. We've sent out some patient portal messages. We don't always get a high yield on that either. Telephone outreach, we do have our community health workers sort of track down some of our patients who are overdue for lead. That is also like a laborious process, but some kids who seem way overdue and seem like they have other immunizations that are overdue and well visits that are overdue she'll track down by phone. We've tried some going out into the community too, and so that hasn't been super successful. We have a mobile unit for our health system that we sent out this last year several times to some of our neighborhoods and got zero response. So I don't know if everybody would have that same experience, but if you're thinking about that type of outreach, we didn't have a lot of success with that. We're doing some home visiting programs. We'll talk a little bit about that in our sort of work that we're doing on our last slide. And then we haven't had a whole lot of success working with WIC. We thought that maybe patients that come to WIC are another potential place, catch them while they're at WIC. During the pandemic, kids were not coming in person to WIC. I think they've recently started that, so that's maybe another opportunity to work with. Partnering with the MCOs hasn't been a very fruitful process so far yet, but maybe that's another place that you could do outreach with. Next slide. The Pathways Hub model is something that I'm not an expert on, but we have here at Metro Health. It's a care coordination model where community health workers really try to address social and medical needs for patients. And then there is some recompensation for that from the MCOs. Lead testing is one of the pathways for the Better Health Pathways Hub that we work with. And so, so our community health worker can get us some credit for closing that lead testing loop. But I think what also is helpful is sometimes addressing needs that the patient feels probably more important than the lead testing, establishing a medical home, dealing with housing, educational and employment needs. So, so that is something that we have put into use. I'm not an expert, but happily to try to point you in the right, connect you to the right people if that's something that you feel would be helpful for your situation. Next slide. All right. We also talked about some of our kids when we're trying to improve our metric numbers. Some of our kids must be getting lead testing elsewhere. We just know from experience that our patients bounce around. And so this graphic shows what percentage of our patients we figured out really did have lead testing elsewhere. If we looked at all our Medicaid patients in our wellness registry that were turning 2 years old in 2021, we have a bucket of 2,724 patients. When we winnow that down to our patients with no lead results in our EHR, that's down to 954 patients. And so what we did last year, I don't recommend this, but you can benefit from our experience, I guess. We had some undergrads who were doing internships with us for Institute of Hope. They looked up every single patient on ImpactSys, and we found 164 of those patients. So that's, I don't know what the percentage is, 17% or something like that of our patients who are missing lead actually had lead tests done elsewhere. You can see our trading partners listed there in the table. So I think that that's an important way. You don't have to track those kids down. They have a medical home elsewhere here. They've had their lead testing at least done elsewhere. So we feel like there must be a better way to do this. And I'll jump to the next slide to talk about that. What we have set up here are some population health queries. Every month, Metro Health does some health information exchange with Akron Children's, Cleveland Clinic. OCHIN is the body that does some electronic health information exchange for our FQHCs in the area, Ohio State. CliniSync is one of our, represents University Hospitals, which is one of our major hospital systems up here that ends up, a lot of our patients end up going there. We hope to get that up and running. I don't know. I don't know if Q1 of 2022 is really realistic anymore, but sometime in 2022. So we do get some outside lead information this way through these monthly population health queries. Happy to get in touch. You can reach out to me if you are interested in that. But in the bottom right, what we're trying to say is, instead of getting them from these, trying to set up these individual agreements with each of these health systems, maybe just getting it directly from ODH, which is sort of like, has all the lead testing information. Maybe that would be a great way for other people to do this without having to set up all these queries with different other health systems. And so I think we've had some conversations with ODH that we'd love to have that as a possibility. The same way we get health information from ODH about COVID vaccines. We know when our patients our pediatric patients get COVID vaccines at a different health system. Why can't we do the same with our lead, so we don't have to spend so much manually effort looking it up? Next slide. I wanted to talk about a case, and I think it's a case that probably you've been in similar situations with, just to talk about why is it important to screen for lead in a timely fashion, and why is it important to get that case management, be really active with that, and at the same time why sometimes it's just challenging, and we need more resources as health systems and better partnerships. So this is a case, at the time of prepared this slide, the patient was 34 months old. In February of 2021, he was seen for a well visit at 28 months old. That was the first time he ever had a lead level done. And so there's, again, why should we do lead testing better in our clinics and during our visits, so we are not faced with a kid who's at 28 months old and getting tested at lead at the very first time, and then having that lead level come back at 18. So they came back maybe within a month. They were got into our lead clinic because the lead level was higher than 10. They were scheduled at our lead clinic, had education done, had the Help Me Grow referral done at the time. And then I think maybe we didn't have our best workflows in place as far as case management, because that patient was lost to follow-up until July 23rd. And at the next follow-up for lead clinic, a few months later, the lead level was up to 80. The patient was admitted, chelation was done, the level came down to 18. The home inspection was done at that time. It found lead in the windows and doorways. This is the home was owned by the grandmother, and she was told by the county board of health that repairs would take months to arrange. The patient was sent home with a cousin to stay with a cousin. When we saw the patient back a few weeks later in lead clinic, the lead level was back up to 31, and he was back in his grandmother's house. It was too rambunctious for the cousin to put up with. And so we said, oh, we've got to find something better. This is the sort of tough resources that, the tough lack of resources that we sometimes are dealt with. Like, there was no other family member to send him with. We decided to try to put him into a temporary shelter that we had called Providence House, so that he could be in a lead safe place. A couple of weeks later, when he went to Providence House to get his testing, like a COVID screen, to be admitted, his lead level was back up to 67 already, and so he had to be readmitted again. He was chelated again, sent again to Providence House this time. It's actually, the saga has gone on for this patient, and I know Jen, who's on the call, probably weeps every time she hears his initials mentioned. But so this is the challenge. We know that it's tough dealing with these, and we can't do it ourselves. We have to work closely with our health departments, with our partners in the community for getting lead safe housings for tough situations like this. Next slide. I think I'm almost done, so we should be able to have some questions. Just so you understand the composition of our team, I know we're really lucky. We've advocated for ourselves. We've gotten some grant funding. We've put together a team. You might decide we only need a part of this team, but I will say that you sort of, the time and personnel that you can put together are very worthwhile. You might decide you just need a medical lead. You might decide you just need a part-time person to do case management. Yeah, I think you'll be the best to figure out what you want in your situation. We have myself and Jen. I have 0.1 time for lead, although I spend probably more than that. We have our full-time pediatric lead nurse. We have our lead. We have our nurse practitioner who mans our lead clinic 1 session per week and participates in some other team meetings. We have a pediatrician through a private grant who helps us with some of our clinical workflows, and we have a community health worker who's also supported by that grant. Next slide. I want to talk about some other work that we have in progress because it's exciting. We have a neighborhood outreach program that we're trying to get off the ground in the next month or so, where we're actually going to do home visits in a focused neighborhood. We found a neighborhood where we felt there was some good engagement, but also high levels of lead poisoning and high levels of missing lead tests. And so we were trying to set that up so that once per week, we'll be going out with our lead nurse and community health worker to do follow-up lead testing and education on kids who have elevated lead levels, but also some lead testing for patients who are overdue for their lead tests, actually just going out and getting it done. We have an OB clinic screening project that's been just about to take off also too, where all our OB patients are asked some lead risk questions on their new patient visits, and they can be plugged in with home inspections if they screen positive, and if they're actually getting their lead tests drawn too, and if they have meet certain criteria, they can get a home inspection. So that's some primary prevention before the baby is even born. We're really excited about that. And Dr. Tacker can probably talk a little bit about this too, but we're trying to do some regional collaboration with our 3 major health systems up here in Cleveland and our several of our federal health centers. So that's exciting for us to think that, this started off with like a couple of physicians here at Metro Health at an Ohio AAP project, and now we're trying to sort of take it to our whole region to get on board with maybe teaming up on measuring how we're doing for lead testing for our region and advocating for more resources. And I think some of the people that are involved in that are on this call. Next slide. Oh, you can go to the next slide. Sorry. So I quickly takeaways. Making it a system quality goal is really helpful. Having that buy-in from the C-suite folks that really helped us move the needle. Good reports are your friend. I'm happy to help try to share my experience with that if you want to talk offline. That's really helpful in being able to show folks in real time from month to month or week to week. How are you doing? How are those changes in workflow resulting in improvements? Drawing the lead in clinic, not the lab, is really best practice. And it doesn't end with drawing the lead test. Really, there's important stuff to do for our patients with elevated lead levels. Next slide. Oh, sorry. I think that's it. You can go to the next slide, Alex. My information is there and helpful. Happy to get any messages from you guys about questions.
Thanks, Matt, for telling this whole odyssey that you went through, because I remember you were part of one of several practices who were part of that QI project that Dr. Bowl and I were getting going a couple of years ago. And it's just wonderful to see how, like you said, it started with a simple little project, and now it's spread through the whole health system, which is really, really great, because I think a lot of times with a lot of these things, it really takes an advocate to make things, make things go. So it looks like we've been dealing with a lot of the questions that have been coming up in the chat as it's been going along, Matt, because some of them have been a little bit tangential to what your discussion was about. So there's a question about just now that just came in, how can we start drawing blood levels at the health department during immunization appointments and / WIC visits? So I'll just comment on that very briefly. That the reason it doesn't happen, it used to happen, there was actually special money from EPA that used to pay for that. And when that money was cut, that was the end of the program. And so testing could be done at these other places. There just has to be some form of funding to get it done, because it doesn't, I think, as has been pointed out here, it takes a whole system to get something done. It isn't just, you plop someone there. In Northern Kentucky, which isn't Ohio, the only kids that the health department is actually allowed to draw blood on are kids who are uninsured at a WIC appointment. So they have special funding from the Commonwealth to do that. So talking about try to coordinate things with the early childhood programs. Yeah, I agreed. The problem, I mean, to be honest, like the problem is a combination of will and money. Those are the two things. If those can be fixed, any of this stuff can happen. And then I'll leave the filter paper at UH. I mean, we have a whole protocol with Cincinnati Children's, and if someone's interested, I can connect you with our outreach phlebotomy folks, because they've helped actually a number of health systems around the state with the technical details of setting up something like that.
I don't have answers, but I will just comment that this is the exact same question that I posed to our little collaborative up here in Northeast Ohio. And so I'm really excited to see people thinking along the same lines, and I'm taking notes on the answers that people are providing. Sorry, Matt, I think I might have cut you off.
No, not at all. I will say that we are mainly, well, up to this point, we're really just drawing venous tests in the clinic. That's it depends on the skill of the staff that's there. And we are just about to sort of start doing some capillary drawing. I'm not sure that we have the right way to do it. If there's a way to do it with filter paper that works for your system, that's great. And I think that I certainly don't mean to say that drawing venous samples is the be all and end all for sure. So I think it takes a lot of time and work to draw. It's extra work for the folks in the clinic, but I think because we have some of the system buy-in and we have some passionate advocates here, that we've been able to sort of keep it going for now.
Hey, are there any other questions that we can answer right now?
Yeah, so I think the question that keeps coming up about the filter paper methods, I think we need to, Alex, can you get the information for the person who's asking that question? And then we can connect them potentially with either someone at UH or someone at like Cincinnati Children's to get some of the technical details, because that might be the best way to do that, because each place has it set up slightly differently. I know Cincinnati Children's is helping Cleveland Clinic trying to because the same analyzer can be used for different stuff. It just there's some protocols that have to be followed for that to work. So there's a little. I'll just tell you, I'm not a lab expert, so I don't want to like give you the answer. That's really what I'm getting at. So.
Great. Well, thank you so much, Dr. Tien, for speaking today, and thank you, Dr. Newman and Dr. Thakor, for answering all the questions. If there are any other questions that come up, I can send them over to Dr. Tien and Dr. Newman, Dr. Thakor to answer those for you all, and you can access any of our resources on the website. I will send out the recording and the slides on Monday. And if there's any other questions that come up right now, you can put those in the chat box.
Maybe I'll just say one last thing, which is
Yeah, of course.
there is a lot of momentum on improving lead testing and lead care management in our region and in the state right now. So I encourage folks to, you won't get what you don't ask for, but it seems like maybe right now is as good a time right now to ask for protected time, added personnel, change in lab workflows, equipment, things like that. I think striking while the iron is hot, it might be a good thing.
Yeah, I couldn't agree more. I've been working in this space for a while, and like the last couple of years has been like the first interest really of around trying to really actually do something about lead that I've seen like since I've come to Ohio. So there's interest from the the governor's office down, and so there's money is flowing, and that's what's making things happen. And like I said before, you need the will, and then you need money, and so I think that this is the time to start working on things. And lead testing is one of the state health improvement program goals. So like that's been kind of baked into the whole like public health system now. So hopefully that will allow for future resources to help keep some of this going.
Great points, Dr. Tan and Dr. Newman. Well, great. Thank you everyone for joining us on this Friday afternoon. And I will send out the survey and everything on Monday. And please let me know if there's any questions before then. And I hope everyone has a great weekend. Thank you again, Dr. Tan, for joining us, Dr. Newman and Dr. Takor for answering the questions and being here. We really appreciate you sharing this information with us.
Thank you very much. Take care.
Thank you.
Appreciate it.
Thank
course.
you.